All right, good morning. See, it's a typical, everybody must be on spring break. It is March, so I guess your spring break is probably in April. Okay. So, welcome to March's PCEP. Today is going to be talk mostly about psychosocial disorders, some basic psychiatric stuff. What we will cover today is psychiatric exam for the medic, mood disorders, schizophrenia, cognitive disorders, excited delirium, a little bit about excited delirium, assessment, management, and psychotropic medicine. Next month, we'll continue the psychiatric and psychosocial issues with some input from law enforcement, particularly dealing with restraint of patients, with taser restraint, dealing with how the law enforcement will or will not get involved in suicide, etc. Before we go, a little revisitation on some medication. We've had a couple of changes recently, and you have to remember to look at this. Levophed, norepinephrine, is now the drug of choice in your protocol. Now, it may not be replaced in everybody's protocol yet because of supply, but Levophed is available. We use it as the drug of choice for septic shock, for cardiogenic shock, and the dose is 4 micrograms per minute. If no response, increase every 5 minutes by 4 micrograms up to a max of 12 micrograms per minute. Now, notice there is no per kilogram in there. We're trying to get a blood pressure, systolic blood pressure of 90, which is a map of about 60 to 65. The PEDS dose is 0.1 milligram per kilo. Now, do not get confused by that because, so just recently we had a 2 microgram per kilo dose given to an adult. Got a blood pressure really nicely. I mean, the blood pressure was about 180 after about a minute, which is a little on the high end. So that's not what we do. So 4 micrograms per minute. So that's a milligram in what? In a 250, or 2 milligrams in 500 gives you 4 micrograms per cc. So do it the easy way. Get your 1 microgram per cc and drip it in as a cc. And if it doesn't go up, go up to 2 cc's per minute. But only in now, I can understand it's confusing when you deal with PEDS doses because PEDS have to do it by weight. So you can just cheat and look at your Broslow tape. That'll tell you. Okay. Now we'll go to psychiatry. Oop. All right. So, as part of our psychiatric exam, we look first at appearance and behavior of the patient, speech, mood and affect, their thought process, content, and insight, judgment, and cognition, what they can understand. So, appearance and behavior, looking at the patient. Are they disheveled, well-kept? Just describe it. Do they have injuries in various stages of healing? For example, a black eye, a hematoma someplace, evidence that they're not taking care of themselves. Their behavior, agitated, do they have eye contact? Do they have lack of eye contact? Are they picking at themselves, pacing about, apparently responding to internal rather than external stimuli, marching to the beat of a different drum. Speech pattern, are their speech slurred, slow, lethargic, very soft, sometimes you can't hardly hear them, rapid, pressured, under, agitated as if they're on amphetamines. Their speech, it may be difficult to differentiate between their speech pattern and their thought pattern, because the two are, intimately joined. So they may be not making any sense, talking, rambling, and just describe it as that. What's their mood and affect? Mood is their predominant emotion. So are they depressed? Are they simply sad? Are they angry? What's their affect? Which is how they describe how the patient expresses emotion. So, do they have a normal, full affect when they're talking to you? Are they flat or inappropriate, labile? Do they start crying and then laughing? What's their thought process? That's how their thoughts are organized. So are they organizing their thoughts in a logical pattern, or are they tangential, that one thing runs to another that doesn't make any sense? Do they have very loose associations? Are they stopping? Are they blocking certain thoughts? Are they blocking thoughts about their safety, for example? Their thought content is what they are thinking about. Are they expressing are they telling you that they're thinking about suicide, they're thinking about killing somebody? Are they delusional? Are they totally divorced from reality? Are they having hallucinations? Now you get hallucinations come in visual, I'm seeing things, or auditory, I'm hearing things. Sometimes both. What's their insight and judgment? Are they aware of their situation? Are they aware of the problem they're in? Are they aware what it means that what they're doing? So, is their insight good? Is it very superficial? Is it totally poor? What's their judgment? Can they make a sound decision? If they have an impaired judgment, they can't make choices on refusal. If you have impaired judgment, if your patient is impaired, they cannot make their own decisions. That's one thing you have to tuck away. So they can't sign a refusal if they have poor judgment, if they're impaired. If you suspect that they're really impaired judgment, same difference. Okay, cognition. Are they oriented? Ability to recognize their current situations and surroundings. We always do a simple thing. Are you alert and oriented times 3 or 4? Do they have normal attention? They can stay on the current situation, or are they tangential? Do they begin to skip all over the thing? They cannot pay attention to what they're doing at that time. Memory. Are they perseverating? We use perseveration a lot. I mean, when people ask repetitive questions, we consider head injury in a motor vehicle accident. The person says, keeps asking what's happening, what's going on, they forget. They also do that in normal, in abnormal psychiatric states. Do they have memory of the event? Do they have memory of questions you're asked? One of the things we test with memory in a regular psychiatric exam, when you're sitting in a physician's office or in the ER, you ask the patient a question, or you give them something to remember, and then 5 minutes later, ask them what it was. That establishes short-term memory. So let's talk a little bit about psychiatric conditions. We'll start with the mood disorders, which we see a lot of. Major depression. So this is not a psychosis. This is a mood disorder. We'll get to psychotic thoughts later. So major depression. So it's described as a pervasive dysphoric mood or lack of interest lasting at least 2 weeks. Dysphoric means you feel bad. Anhedonic means you don't have any pleasure in anything. Guilt, hopelessness, suicidal thoughts, self-reproach, person sitting around, I rue this, I rue the day that, totally depressed. But it has to last at least 2 weeks to be in a major depression. You have vegetative symptoms, primarily fatigue, loss of appetite, and primarily sleeplessness, rather than sleeping. Major depressives don't really sit around and sleep. And we always think, oh, they haven't got out of bed, they must be depressed. Well, if they're sleeping, that's probably not depression. It's probably another problem. So sleeplessness is they just don't sleep, or they don't sleep well. Inability to concentrate, psychomotor agitation. Often there's an underlying medical disorder or substance abuse thing with alcoholics. When I say they're really a depressive who's self-medicating. Primary mood disorders, so real major depressions, respond very well to antidepressants. Bipolar disorder, it's mostly characterized by the mania. So that's manic depressiveness, and the episodes of mania occur more frequently and they're more severe. And then it's followed by more severe depression. But primarily the manic state, the manic state is what characterizes bipolar disorder. Symptoms in the mania are decreased need for sleep, racing thought. These people are just up running. They're up in the middle of the night tweeting. Rapid pressured speech. Yeah. Rapid pressured speech, grandiose ideas. Many believe themselves to be famous, rich, sexy, great, have special powers. The manic phase is usually followed by a severe depressive. And as they get older, that gets more manic and more depression. And these are managed with mood stabilizers, lithium, Depakote. Now, Dysthymic disorder, which is a less severe form of depression, is just characterized by lifelong gloomy outlook on life. Sort of the guy you don't really want to have over for, dinner, because they're always grumpy. They're always depressed. It says here women are more often affected. I'm not really sure that that's true, but we'll say that that's true. The vegetative symptoms, the sleeplessness, the fatigue and all that, is not as severe as they are in depression, and it doesn't last more than 2 weeks. You get the real, once a month you feel really down kind of thing, and then it goes away. Or it's not, but you're never always you're always the glass is half full kind of person. It's also associated with substance abuse disorders, alcoholism mostly. Then anxiety disorders. Well, panic disorders are recurring acute attacks of severe anxiety characterized by autonomic signs of catecholamine. So they have racing heart, palpitations, sweaty, clammy skin, all the autonomic kind of sympathetic stimulation. Their presenting complaints often mimic real medical conditions like congestive failure, I can't breathe, I'm having chest pain, I'm having palpitations, so this is just a generalized panic disorder. It's the same thing as somebody who takes too much Red Bull and caffeine and gets that kind of high output catecholamine release, except they didn't have it. That happens just off their own. Then there's generalized anxiety disorders, which is a free-floating anxiety without an actual anxiety attack. So they don't have the sympathetic attack. They just are always anxious. And I think all of us have known somebody who's always nervous about everything. Persistent worry, they have insomnia, they have muscle tension headaches, irritable because they don't sleep well. Symptoms are chronic. And those are best, now mood disorder, anxiety is best treated with benzos and with SSRIs, things that take off the anxiety. Now part of one of the types of anxiety disorders, phobic disorders, you have an inherent fear and avoidance of disease, for example. One of my professors at the med school was a definite phobic. He would never go into a room without putting his hand in his white coat and opening the door with that so that he would never get germs on his hands. The fact that he was a neurosurgeon was a little bit disturbing. But it's, this is just an anxiety disorder. And so many people have social phobia. They cannot go to a social situation. They can't be in a room with people because they feel totally anxious. Now, post-traumatic stress is anxiety to a severe psychosocial stressor. So memories, so post-traumatic stress characterized by intrusive memories, nightmares, what we call survivor's guilt, somebody who survives a plane wreck. Obviously, we're mostly familiar with post-traumatic stress from the military now, having, nightmares frequently associated with substance abuse as a self-medication. Obsessive compulsive, these are intrusive thoughts or images that can't be eliminated. So obsessive thoughts include things about contamination, bacteria, obsessive thoughts about sexual perversions or imagined sexual perversions. Compulsive behavior includes compulsive hand washing, repetitive checking, counting. Captain Queeg of the in the Caine Mutiny was an obsessive compulsive, hand washing, obsessively counting things in the storeroom. All right, now we get into the real psychotic disorders, including schizophrenia. Schizophrenia and the other psychotic disorders are defined by the presence of psychotic symptoms. Psychotic symptoms are delusions, which are fixed, false beliefs, not amenable to facts. It can be persecution, feel like you're being followed, harassed, conspired against, grandiose delusions that you have special powers or abilities, and bizarre delusion, you have totally absurd thought. Hallucinations are false sensory perceptions. They can, remember, it can be auditory or visual. Most of your psychotics have auditory hallucinations. Schizophrenia is the most common type of psychosis. Accounts for 25% of all hospitalized patients. Now, that obviously includes psychiatric hospitals. Evidence suggests that there's probably an organic / genetic cause, probably to do with production of serotonin and dopamine and how those react in your brain. The following things have to be present for at least 1 month. So you can't diagnose someone as schizophrenic on the first week. You have to be there a month. Deterioration in function, in normal function of life. And then active phase symptoms, including delusions, hallucinations, disorganized speech or behavior, sometimes catatonic behavior. People sit there and they are basically locked in place. They don't function at all. You can't. They appear to be awake, but they're not responding to you at all. Or absence of mood, so flat, total flat affect in the presence of decreased function, apparent delusions, disorganized speech. Now, schizophrenia usually starts in adolescence, like late teenager. You may have some premonitory symptoms. At the very latest, it happens in early childhood, or early adulthood, usually before age 25. There's a prodromal phase, which you might have noticed as a teenager, early, that the prodromal phase is that there's a gradual deterioration of function. So a kid has been doing well in school, and at about junior, senior, starts decreasing the ability to function in school. His grades go down. Parents think, oh, is he on drugs? She on drugs? Are they doing something? You know, and then they may get better. But then they get an active phase at some point. So the first time is usually somewhere between 17 and 25. Characteristics of the active phase are disorganized thinking and behavior. They usually stop taking care of themselves. They look kind of disheveled, which is kind of hard to sort out when you're a late teenager. That they may be into grunge, into whatever else. You think they may have poor judgment, poor associations. You can't make sense of what they want to do. Loss of logical connection between one thought and the next thought. So when you're talking to them, they bounce about. And once again, the parent thinks, are they on drugs? What are they doing? Inattention, they don't seem to enjoy anything anymore. And then a flattening of affect, a blunting of emotion. Now we treat schizophrenia, they work, antipsychotic meds, think Haldol, things like that, work well for hallucinations and delusions. They don't do well for the other effects, the not paying attention, the disjointed thought process, etc. But it treats the hallucinations. So if they're being driven by a persecutory thought process that somebody's after them, or somebody is telling them to do something like harm themselves or something, the the antipsychotics treat the hallucinations reasonably well, but they don't do much for the rest. Now, schizophreniform disorder is not a true psychotic. It's the patients meet the criteria for schizophrenia, but the symptoms only last at the most up to 6 months. So they might be initially diagnosed as schizophrenic, but then it goes away and they seem to normal. So that's a schizophreniform disorder. Small point. Other psychotic disorders. A brief psychotic disorder is acute psychosis after a traumatic event. As the guy is writing, I don't know if you can see that, he says, the psychiatrist is writing down, just plain nuts. That's JPN in our thing, and then there's JFN, which is much worse. So, brief psychotic disorder is acute psychosis after a traumatic event. It's almost like post-traumatic stress. So, you could have been in combat, have a recent death or loss of a loved one. I think Mark threw in marriage as a thing. I don't think that really belongs in that list. Natural disasters, people who have brief psychotic events after, surviving earthquakes and things like that, with a lot of disruption of normal social stuff. Other psychotic disorders, delusional disorder. This is characterized by non-bizarre delusions. It's actually delusions that kind of make sense, but they're not there really. So you think, well, I'm being followed by the police, which is probably true. Well, it could be true. That's not very bizarre, but it's a delusion if it's not true. If you're fixated on the idea that you're being followed or that somebody is monitoring you, of course, now you have a cell phone and you know that the NSA could be monitoring you every day. They're not, but that could be a delusion. It differs from schizophrenia in that these people have the delusions, but their activities of daily living are not affected. So they don't have the vegetative, they don't have the sleeping issues, they don't have, they can still enjoy things. They just are convinced that this is happening. So, it's usually middle to late adulthood, and it could be persecution, they're being conspired against. It could be unproven jealousy. That their spouse or significant other is cheating on them. Well, no, that's actually not a bizarre delusion. But if it's not true, and you persist in that, that's nuts. That's a delusion. It could be somatic. People think they're affected by parasites. We get people now and again who come in and say they've got bugs, they've got things. I've had patients who were sure that they had contracted a sexually transmitted disease. And, well, that's not bizarre. That's not bizarre. That's a reasonable thing, except that I asked the person when his sexual contact was, and it had been 20 minutes before he came to the hospital. Well, it's a little bit hard to figure that out at that point. Now, that's a bizarre, that's a non-bizarre delusion. Okay. Cognitive disorders. Dementia. Disturbance of cognitive functioning, disturbance of memory, judgment, abstract thinking, language, disturbance in language. We see a lot of dementia. It's a slow onset, usually. The impairment may mask an underlying medical, it may be due to a medical disease. The most common kind of thing we see are, of dementias are, of course, old older age dementia, senile dementia, Alzheimer's disease, etc. But it's a slow onset, generally. There may be reversible causes, so some dementia can be metabolically related, maybe due to, especially in today's days, people take multi-medications from multi-doctors, and they're not always cross-checked to see if they have a cognitive depression part of it. And people who are depressed, particularly older persons, seem to be more demented, but they may do well if they get treated for their depression. Delirium, on the other hand, is a global impairment in your cognitive functioning. Decreased consciousness, abnormal vitals. The course of delirium is acute, and there's often visual hallucinations associated with delirium, and they're really bothersome to the patient. Whereas when you have psychotic hallucinations, often the psychotics are fairly indifferent to, especially visual hallucinations. Somebody's there, but there's really nobody there, but there's this person here. They're much more bothered by the persistent voices telling them to do something, but they don't care so much that there's somebody in the room that's not really in the room. But in delirium, you want to try to, this is a very complicated confusional thing, and delirium, we have to rule out the presence of a real physical problem. So, I mean, some people are delirious when they have a fever. The fever may be due to meningitis, for example, may be due to encephalitis. They may have a delirium because they've got a drug overdose. They've got a drug reaction. So we have to get to the bottom. They may be in a delirium because of a head injury. This is too confusing. I don't want to deal with that one. I don't know. Okay, then there are some neurodevelopmental disorders, and we get to see that as EMTs. Autism spectrum disorder. We now call it autism spectrum disorder. It used to includes things like what used to be called Asperger's. We try not to diagnose people with Asperger's now. I guess it's not PC to do so. The spectrum disorder means exactly what it says. There are people who are high functioning and people who are low functioning. And there's a spectrum, and there are no two autistic persons who are exactly the same. Sort of like snowflakes. Classically, they have difficulty in communication, forming relationships, and using language and abstract concepts, except that there's some really extremely high functioning autism spectrum people who are quite brilliant in math, quite brilliant in communicating with non-human species. There's all sorts of, so it's a huge spectrum. The extreme is the kid who sits all day and bangs his head against the side of the wall, and so you end up putting a helmet on him. And then the other extreme, you can look at, there's a couple of well-known authors out there who who are autism spectrum. Asperger's disorder, childhood disintegrative disorder, there's a mouthful, pervasive developmental disorder. There's a lot of information on this website there. Other disorders that we see commonly. Substance-induced disorder, so intoxication, we see that a great deal. Intoxication with alcohol, with other drugs. Maladaptive behavior, judgment impairment, perceptual abnormalities, loss of attention, emotional control, psychomotor issues, all associated with intoxication. Features of intoxication differ based on the substance, and then we have withdrawal syndromes, which is cessation or reduction in use of a substance of abuse. Generally speaking, when you have a withdrawal, which means that you're habituated or addicted to that, generally speaking, most drugs that you withdraw from, you have a whole withdrawal, that you get an increase in psychomotor agitation, you get increased heart rate, respiratory rate, blood pressure, and at some point you may have a neurologic meltdown and have a seizure. Except for the opiates. When you withdraw rapidly from opiates, most people almost nobody has a seizure. Not true of any of the benzodiazepines, not true of alcohol, not true of sleeping meds, almost everything that you're addicted to, you could have a major motor seizure from. The only narcotic that actually has a major motor seizure, if you rapidly withdraw them, is methadone, curiously. So, as a rule, that's why I don't worry about you giving 2 milligrams, 4 milligrams of Narcan to an apneic junkie. You're not going to have them have a seizure after the fact. They're going to hate you when they wake up, but they're not going to seize. And withdrawal causes all sorts of, before the seizure, it causes all sorts of psychosocial issues. I mean, they will be very agitated, very disruptive. Somatoform disorders. These are complaints or symptoms for which you cannot establish a medical diagnosis. Now, we have to cover that a little bit with the understanding that sometimes we aren't good enough to actually come up with medical diagnosis, but sometimes we are, and there is no medical diagnosis there. So somatization is medically unrelated symptoms in multiple organ symptoms, and you cannot find any medical cause for these symptoms. You can't find any abnormality in their lab work, any abnormality in their x-rays or CAT scans or MRIs, and they still have these symptoms in multiple organ systems. So they're just, yeah, JPN. Hypochondriasis. These people are preoccupied. They're sure they have an illness. They're sure they're going to die. Well, that's true of all of us, I suppose. But they're sure they're going to die today or tomorrow if they don't find it. They're sure they have this. They're sure they've got this kind of disease. Then pain disorders. Pain is the sole complaint, and you cannot find a medical support for that particular ailment. Why do you have pain? Why do you have generalized weakness and pain? the eating disorders. Now, this is an interesting statistic. Anorexia nervosa has a 10% mortality rate. That's higher than any other psychiatric or psychosocial thing. Psychotics, you only wish they were dying. They don't. I mean, I don't mean it that way, but I mean, these people don't die of psychosis. They just make you want to kill yourself when you're trying to deal with them over and over and over. And my God, if one is in, if one is in your family, I mean, it consumes your whole life, the rest of your life. But the anorectics die. 10% of them die because of the extreme metabolic derangements that occur mostly in their electrolytes. I mean, my common joke, Karen Carpenter died of torsades due to her anorexia. She had a magnesium, potassium, etc. deficiency. So, eating disorders are characterized by a premorbid personality, which is high achieving, perfectionist, very highly controlled, and then they develop this distorted attitude toward weight gain, eating, and food. They have this morbid fear of fatness. They think that their emaciation is not a big deal. They don't think they need nutritional support. They often do excessive exercising up to the point, binge eating and purging, characterized by less than 15% of ideal body weight. They have hypothermia, acrocyanosis, that kind of, that's a sympathetic discharge, giving sort of mottled skin because of their sympathetic discharge closing. It's like babies are acrocyanotic. They're often mottled in the first few hours of their life. EKG disturbances, everything from bradycardia to PVCs to prolonged QT syndromes and torsades, hypotension, hypokalemia, hypochloremia, hypomagnesemia. It's a starvation syndrome. Same thing happened in prisoner of war camps and concentration camps. Emaciation, they lose their hair, or they develop very what's called lanugo hair. Lanugo hair is that soft kind of hair that occurs on babies, on their cheeks and all, and it disappears as they grow. That's called a lanugo hair. And their hair is like that. They get it developing on their face as well. You can see on this one on her cheek there. Cerebral atrophy, which is probably why they can't pay attention to the fact they're not eating. Amenorrhea, altered mentation, etc. Bulimia is the other end. Bulimics are actually they have recurring episodes of binge eating and then activities to prevent throwing up. But they're generally of normal weight. But they also will develop electrolyte disturbances because of repetitive throwing up. And because of the throwing up, they get eroded dentition. Acids have a tendency to strip enamel off teeth. The old days, we used to take you could take a baby tooth, when you'd lose a baby tooth, throw it in a cup of Coke, and it would be literally gone by the next day. Makes you think twice about having a Coke. Halitosis. People who throw up a lot don't have bad breath too. Their teeth are eroding. Hair loss, muscle cramps, the usual thing, but they don't have as high a mortality rate as the anorectics. Personality disorders. Personality disorder is a lifelong pattern of behavior not related to illness, causing distress or impairment in social and occupational functioning. It is not a psychosis, it's a personality disorder. And so you can have the paranoid, schizoid, or sometimes it's called the schizotypical disorder. These are odd, eccentric people, withdrawn, suspicious, inhibited, no friends, they're overly sensitive, but their activities of daily living, they can function. They do function. They don't have hallucinations. They don't have the other psychotic symptoms. They're just odd people. Then antisocial, histrionic, borderline. Most of these actually are borderline, because a borderline person is antisocial, histrionic, narcissistic, all in one lump. These are emotional, dramatic, angry people often. They can be very seductive when they want to get you to do something. And they'll turn on you in a minute when you don't do it. They're impulsive, erratic. They can never stay in school. They can never, it's always somebody else's fault. They can never, you know, my teachers aren't good enough to teach me. I have a borderline in my family, and it's, you know, they are often, they're extremely histrionic. They're the classic prima donnas when they want to be. Very narcissistic, and then, but they also have a tendency to self-medicate, mostly with marijuana and other things. Then there's the dependent or avoidant obsessive compulsive person who is not a psychotic. They just they're anxious, fearful, nervous, cautious all their life. Just a personality disorder. Last thing for a break here, excited delirium. Hopefully we'll go into this more next month too, but excited delirium is the extreme end of the hyperadrenergic syndrome. Sudden onset with bizarre and aggressive behavior, often shouting, very paranoid, so paranoid you don't know if they're having hallucinations. They're in a panic usually. They may be very violent toward others, and they have unexpected physical strength. And also hyperthermia, tactile hyperthermia. You can touch them and they feel hot, and you can take their temperature and they are hot. It's often associated with illicit stimulant use, and there's probably underlying mental health issue as well, whether it's true psychosis or a personality disorder. Now, there's sort of an interesting background of excited delirium, because this came, American College of Emergency Physicians did a white paper in 2009, and ACEP and the National Association of EMS Physicians and NASEMSO, which is the National Association of State EMS Medical Officers, accepted the diagnosis of excited delirium, which has been rejected by the Brits and the Australians, and I think the Canadians also, because they think that tagging someone with excited delirium is a cop-out. No pun intended. It's a it's a way to let law enforcement off the hook for these people who die in an episode of what we are calling excited delirium. They say, because if you call it a medical condition, then it avoids the fact that a lot of the issues with excited delirium are caused by excessive force and excessive restraint being applied to the person who's acting this way. And the white paper that PCEP did looked at 1 million police encounters. And in that 1 million police encounters, there was 698 use of force by police in restraining people. 24 patients had 6 out of these 10 things. And you can see, many of those persons who had the force applied had a sudden cardiac arrest, basically. Now, first of all, the features are pain tolerance. 100% of them had pain tolerance. You could hurt them and they weren't going to stop. So if you're applying a force to them to restrain them, that you think that a normal person would say, hey, I'm not going to resist this because it hurts. They don't see this. 100% of them have tachypnea. Almost 100% are sweating. Almost 100% are agitated. They have tactile hyperthermia. They feel hot. They are hot. 90% are police non-compliant. You ask them to do something, tell them to do something, they're not going to do it. They're going to continue to fight. 90% of them have lack of tiring, so they keep fighting. They keep exerting all this, they keep having all this excessive catecholamine. They have unusual strength because they don't know what's hurting them. This used to be true of PCP, phencyclidine. People used to have that too. I saw one of the guys here break a guy's leg. One of the police break a guy's leg with a stick and he didn't know that his leg was broken, and he kept going. They're inappropriately clothed. For what that means is they're not dressed, in fancy outfits. They're inappropriately clothed for the time. So they're running around half naked in the middle of the night in a snowstorm, inappropriately clothed. And then 10%, which of that would be 70 of these people, had a bizarre thing, which is called mirror glass attraction. They have this mental fixation on mirrors or glass, like windows of vehicles that they can apparently see a reflection in, and they attack them. They break glass. One of the more recent one we have was attacking a C-Tran bus windows. So, all right. Let's take a break. We'll talk about assessment management, and we've got some really interesting case reviews today too. Psychiatric issues. So, pre-hospital decision making. Is the patient stable? Is the patient unstable? Is there an underlying serious medical condition, or this related to trauma, etc., or hypoglycemia? Is psychiatric consultation necessary? Should the patient be forcibly detained for emergency evaluation? So, physical restraint. Physical restraint will be required for violent behavior. It is also necessary if the patient says they are potentially violent. and it's necessary during medical conditions which cause disturbed behavior. So a patient who is acting psychotic, agitated, violent due to hypoglycemia or meningitis, encephalitis, a delirium state needs to be restrained. Initial evaluation of behavioral disorder, so history, so medical and psych history, history of medication, drugs, alcohol, and the onset of this behavioral mood change. If it was rapid, it may be indicative of a medical condition. So your medical causes, quick survey of medical causes of behavioral disorder, CNS infection, meningitis, encephalitis, intoxication or withdrawal syndromes, hypoglycemia, hypertensive encephalopathy, hypoxia, intracranial hemorrhage, poisonings, CNS trauma or seizure disorder, postictal state, acute organ system failure, such as acute liver failure, etc. Mental status exam. Do a quick mental status exam of the patient to determine functional psychiatric causes from organic causes. An abnormal mental status exam suggests an organic cause rather than a psychiatric cause. So level of consciousness, whether they have spontaneous speech, language comprehension, of course, it's confusion if they don't speak English, communication ability, and appearance of the patient. Physical exam is to primarily identify easily, quickly treated disorders that could impact behavior. So abnormal vital signs, including O2, SAT, and CO2 if possible, fever, hypothermia, hypoglycemia, etc. In the elderly, we see a lot of this. So emergency behavioral syndromes in the elderly, delirium, medication, especially anticholinergic types of medication, physical illness, infections, metabolic diseases, drug withdrawal states. Don't forget that old people have drug issues as well. Dementia, Alzheimer's disease, and multi-infarct dementia. However, dementia, treatable causes of dementia include depression, drugs, polypharmacy, endocrine disorders, including thyroid, hypothyroid disease, including Addison's disease, low steroids, subdural hematomas in old, chronic subdurals will cause a dementia-like appearance. It could be treatable. Once again, alcohol dependency affects people that appear to be demented. Medications, your psychotropic drugs, drugs that they may be taking for their underlying depressions, etc. Digitalis overdoses will cause cause behavioral syndromes, even cimetidine. So, taking it for their GERD, and they end up getting a demented situation, anticonvulsant medications, physical illness, renal hepatic failure, COPD, increase in CO2, electrolyte imbalances, cardiovascular disease, and then depression, including bipolar disease. Even manic depressives get old. Alcohol intoxication and dependency is still right up there as the causes of dementia or related to dementia in older persons. So, general consideration: protect yourself, protect your crew. Summon law enforcement, and we're going to talk with law enforcement next month. Now, use of force by law enforcement personnel is appropriate if the patient is so agitated that other persons are at risk, or if they're so violent that other persons are at risk. But law enforcement will tell you that if no one else is at risk except the person, they have the option to engage or not engage. Request mental health professional as needed. If there's no evidence of immediate danger, approach the patient, be calm, show self-confidence, concern for the patient, reassure the patient that they'll be taken someplace where people will be interested in helping them. It helps for one EMT to establish rapport and deal with the patient. Transport the patient as quickly as possible without causing undue harm. Now, if they have a significant mental disorder and are refusing transport, a police officer may place the patient on hold. We'll talk more about that next time. Should the officer elect not to put the person on hold and the person is significantly mentally impaired, contact the designated mental health professional. We have all those phone numbers in your orders. DMHP may request you transport the patient for emergency evaluation and will instruct law enforcement to put the person in custody. And you can use physical and chemical sedation as per protocol. Don't be alone with a psychiatric patient. Have enough help to restrain a violent patient. Consider the armed patient homicidal as well as suicidal, and that's where the police come into effect. Physical restraint, minimum restraint to ensure patient care and safe transport. So soft restraints may be sufficient. Law enforcement may need to help out. Don't endanger yourself or your crew. Put the patient face up, never prone. About half of the cases where they have had a bad outcome from what was probably a agitated delirium, excited delirium, the patient was hogtied and put face down. Secure all extremities to the backboard. The sequence is the lower extremities first, they're stronger usually. So do the lower extremities and then restrain the patient's arms. C-spine control goes on if they're thrashing their head about. Secure backboard onto gurney. Always evaluate patient's respiratory and cardiac status. Monitor SpO2 if possible. Don't tighten the chest. Don't over tighten the chest straps. For chemical sedation, you have to have first enough medical personnel to safely restrain the patient, but treat medical causes of combativeness first, like hypoxia, head injury, hypoglycemia, excited delirium is a second thought here. Now, your orders are straightforward, although people do get confused by it. If the patient's agitation is unknown or you suspect it to be psychiatric in origin, you start out using the antipsychotic drugs first. And we have Haldol. I wish we had a napsine, but a napsine is still not available. We have Haldol, 2 to 2.5 milligrams to 5 milligrams IV or IM. Now, if the patient is really agitated and they're an adult, go for the bigger dose. You can repeat that dose, and you can repeat your doses every 15 minutes. Hopefully you're not with the patient much longer than that, up to a total of 10 milligram max dose for Haldol. Now, the alternative, if you don't have Haldol, we have Geodon. Geodon is only given IM, 10 milligrams IM. You can repeat that dose 15 minutes later if they're not doing okay, if they're not doing better, up to a max of 20 milligrams. Now, if they develop dystonic reaction or akathisia, which is that creepy crawly, almost like agitated delirium, creepy crawly, I can't sit still, and you're killing me, this is driving me crazy, give them Benadryl. For an adult, I would give 25 milligrams. And if they're not well in 5 or 10 minutes, give them about 2.5 milligrams of Valium or Versed to mellow it out. Now, if you think their agitation is drug-induced, whether it may have underlying psychotic behavior or not, if you think it's due to drug, methamphetamine, whatever, then we start out with Versed and give Versed IV or IM up to a total of 10 milligrams. So, you're giving them 5 milligrams of Versed, nothing's happened. You give them, 15 minutes later, you give them another 5 milligrams, up to the total of 10. 15 minutes later, or 5 minutes, or what your tolerance is at that point, if they're still agitated after full dose of either drug, so if it's antipsychotic, if you think you're going to treat them with Haldol first, you've gone up to 10 milligrams and they're no better, then you switch and you start giving Versed as a sedative. If you think it's drug induced, you start out with Versed to full dose, and if they're still agitated and wacky, go to the Haldol or Geodon. Now, the patient must be on a monitor, cardiac monitor, and you're looking for anything abnormal. You wouldn't use Haldol, wouldn't use Geodon on a patient if you thought you had a prolonged QT, and if they're already taking drugs or things that prolong the QT, you would want to try to avoid that. Now, for excited delirium, you say, how do I know this is really excited delirium? Well, here's a simple hint. If the person is so agitated, so aggressive, so bizarre, that you cannot get an IV started in them, let's just call them excited delirium. And you give them both, you give them full bore both drugs. And I give them 10 milligrams IM Versed, give that first because it works faster, and then give them 10 milligrams of Haldol IM immediately thereafter, or 20 milligrams of Geodon. Don't give Geodon and Haldol. One or the other. Okay, so any questions or any worries about that? So, okay, 4. Now.
You got a question?
Yeah.
So, I have 2 questions. Between Haldol and Geodon, which one works better?
And why do we only give IM Geodon?
Because that's the only way it can be given. Manufacturer says that. It cannot be given IV. I suppose we could try it IV and see what happens, but I don't think it's a good idea. Manufacturer said the only way it can be given is IM.
Between Haldol and Geodon, which one works better?
I don't know. Which one works faster is the question. Probably Haldol works faster. Haldol, there's a lot of experience with Haldol. Geodon is fairly new. It's been, what, around 10 years maybe?
Yeah, we used to use it a little bit in the hospital, but we don't use it.
No. Haldol has been around a long time. I mean, my preference I liked anapsine better than anything because I could also use anapsine for nausea. Haldol doesn't work as well for nausea, but Haldol has tremendous experience. I mean, I think they must have invented Haldol at Denver General because they give it sort of ad lib. If you come in and you're agitated, or you spit or get angry or act bad to the nurses, they start giving you 5 milligrams of Haldol until nice. And they've had tremendous doses of Haldol. I don't think it's a question for us of what we can get. Can't get anapsine anymore. Haldol has been variously available and not available. Geodon is there, so it's just a backup for you.
They both last the same amount of time.
Yeah. But for somebody who you cannot get a line started in, I just assume that person is so agitated that we're going to call it, if it's not excited delirium, it's the next best thing. So, I just do that. So a quick review of some medications you're going to run into in the field, and we'll start right away with the psychotropic medications. I mean, these may be taken by patients, or you may give them. Antipsychotic medications, the monoamine oxidase, they block dopamine receptors in the CNS, and the side effect. So we give these are taken by patients for acute psychotic episodes. Side effects are dystonias, so Parkinsonian-like effects, akathisia, that creepy crawly feeling where you get really agitated, anticholinergic effects, mostly dry mouth, that sort of stuff. Cardiovascular side effects, what anticholinergic do. With high dose of some of these medications, you get torsades. You can get what's called a neuroleptic malignant syndrome. We used to see that occasionally.
It's very rare.
Yeah.
It's out there.
And rigidity, fever, autonomic instability. So
usually that's with prolonged administration,
right,
rather than one single dose.
So commonly used antipsychotics, this on this side are the most common ones: thorazine, stelazine, prolixin, and then Navane, and then our favorite at the bottom, Haldol and anapsine, haloperidol and droperidol. So these are all pretty common, and you can get prolonged QT syndrome from any of these drugs. Now it takes huge doses all by itself. In all the time, we've been using anapsine and/or Haldol and Geodon we started in 1986 using anapsine, and we have never had a prolonged QT, a significant prolonged QT syndrome in that entire country. We use a reasonable dosage. These have all been black boxed by the FDA, which means they put them in a warning category that, and if you read it says in high doses that can cause QT prolongation. Well, these are really high doses. They're like 10 times the dose we use. So now I did have one patient who was who I saw in the department that might have had a slight prolongation of the QT, but that's because she was on 1 or 2 QT prolonging drugs to start with. I would not use Haldol on a patient if your history of medications the patient's on, if the patient was taking amiodarone orally, I would not give them Haldol. I would give them something else. I would use Versed to mellow them out rather than using an antipsychotic. Because you're just going to, they're going to have a prolonged QT. That's how amiodarone works, prolonging the QT. Atypical agents, clozapine, which is used in schizophrenics. It causes severe extrapyramidal symptoms as well, tardive dyskinesia, basically a Parkinsonian-like syndrome. They will prolong your QT, very sedating, can cause seizures, respiratory depressant arrest, so it's a great drug. Risperidone is a serotonin dopamine antagonist. Low risk of EPS effects, but it does cause insomnia, sedation, and QT prolongation. So all these, if you suspect anybody who's on a psychotropic medication, if you think that that they may be having an effect due to over treatment with the drug or intentional overdose, they need to be on a monitor, because they will have some of these will go to a Torsades effect. Zyprexa has really no EPS effects, but does cause weight gain. Ketiapine, which is Seroquel, is mostly sedative and orthostatic hypotension. So patient may be complaining that they get dizzy every time they stand up. Then the anxiolytics. We're well familiar with anxiolytic drugs. The benzos, they're used for panic reactions, for emotional distress, anxiety, agitation. We use it for seizure control, muscle relaxation, and it's used in treating withdrawal, particularly from alcohol. Side effects we know, mostly decreased respiratory effort. Now it says the effects can be reversed with flumazenol, romazicon. We don't use romazicon in the field. People say, why don't we have it? Because we don't use it because, first of all, we don't overdose people. We don't overdose people with flumazenol. The basic, or with benzos, the major use of flumazenol is for medical procedures where you may have over-sedated the patient. It was invented because physicians were getting they were getting respiratory depression, and for some reason an endoscopist can't figure out that if you have respiratory depression on a patient, you should ventilate them. And so they wanted something that could quickly reverse their thing. So flumazenol was invented, and it works. But the side effect of that is it causes immediate withdrawal of somebody who might be on a chronic benzos. And immediate withdrawal ends up in seizures. So we don't use it in the field. We don't have any reason for it because you guys are experts in managing ventilation. You breathe the patient. If you have respiratory depression, the first thing you do is breathe the patient, ventilate it. Commonly used benzos: Xanax, Transine, Valium, Librium. Kobe.
Does anesthesiologist carry that? Like Dennis?
Like Dennis? Well, you're thinking of an anesthesiologist at a dental office. I would think that they might well have that around. I don't know. We have it available in
They're the only ones that do use it.
Yeah.
You know, they use it for procedures that are short, and
Yep.
patients that are not on chronic
Yeah.
therapies.
Yeah,
We don't use it in the ear at all.
yeah,
We'll just mask the airway like you said. You know,
yeah.
Intubated if they need to be intubated.
In my career at the ED, I went to the endoscopy lab twice for seizures that were caused by patient came out of their endoscopy procedure and anesthesia gave them some romazicon, and a few minutes later the patient began seizing. And in both cases, no one had tumbled to the fact that the patient had been on chronic Xanax, for example, for years for the panic disorder. So we just don't use it. If we manage an airway, we manage an airway by managing the airway. That doesn't mean you shouldn't give them Narcan, because remember, nobody seizes after the Narcan, except for infants and people who are on methadone. There's a couple of hypnotics, the sleeping pills that are in the benzo thing, and people take these things on a daily basis often. Dalmane, Restoril, Halcyon are all benzodiazepine-based sleepers. Psychic antidepressants, our favorites: amitriptyline, imipramine, nortriptyline, doxepin, etc. Often they're monoamine oxidase inhibitors, and they will inhibit reuptake of serotonin and norepinephrine. So we use them for major depression. They're also effective for dysthymic disorders, panic disorders, etc. Also used in kids for enuresis often. Problem is there's a very low, as you know, there's a very low difference between the therapeutic effect and the toxic effect. So side effect of all these, even in therapeutic doses, are anticholinergic and cardiotoxic. T-wave changes, prolonged QT, AV blocks, ventricular dysrhythmias, particularly VTAC and torsades. We know the treatment. Treatment is bicarbonate, so a milliequivalent per kilo as an IV, and then put another amp amp in the bag you're running to the patient. And if they have evidence of QT prolongation, if you can read it, or widening of the QRS, start them on magnesium as well. Monoamine oxidase inhibitors increase norepinephrine and serotonin in the CNS. Brand names Nardil, Parnate, and Aprezoline. And they're also present in a lot of herbs that people take over the counter. You have to take that into effect too. Ginkgo, ginseng, turmeric, and even licorice increases norepinephrine and serotonin. We use those for major depressions. Side effects are they may precipitate a manic episode. They will potentiate sympathomimetics, oral hypoglycemics, and other anticholinergic, and may precipitate hypertensive crisis. So if you go out there and the patient's taking Nardil and they're also drinking turmeric tea and they've just taken their ginkgo for the morning and they're hypertensive, that's probably the reason. SSRIs, the selective serotonin reuptake inhibitors. Prozac, Paxil, Zoloft, Lexapro. Reasonably good drugs for depression, rare side effects. You can get what's called a serotonin syndrome, which is elevated, well, hypertension, headache, increase in autonomic in sympathetic activity, and it is somewhat GI irritable. Here's your serotonin syndrome: restlessness, hallucination, lack of coordination, rapid heartbeat, elevation of all your sympathetic stuff, rapid changes in blood pressure, hypertension, and then hypotension, overactive reflexes, nausea, vomiting, diarrhea. How your whole sympathetic system is on overload. What would you best treat that with? Benzos. Hyperadrenergic syndrome. Then there's combination tricyclic and SSRI drugs, get the best of everything. Effexor is one of venlafaxine. Side effects of tricyclic and SSRIs are hypertension, and if you discontinue it rapidly, you get a withdrawal syndrome. So these are drugs that have to be tapered. So when people run out of money and they don't have that drug, they could have a withdrawal syndrome. Bupropion or Wellbutrin inhibits the reuptake of norepinephrine and dopamine, and it causes basically the same thing if you withdraw. So you have to taper to get off these drugs. Combination drugs, Surzone, blocks serotonin receptors, very few side effects. Remeron increases the release of norepinephrine and serotonin. You know, there's a commonality here. All these things increase serotonin level, increase norepinephrine in the brain, but they have fairly low side effects. Now, then the mood stabilizers, which you use for manic depressive, for bipolar disease. Lithium keeps the patient more stable and less likely to have a manic episode. The problem with that is that it's also a fairly narrow therapeutic window. Lithium substitutes for sodium in neural cells, and so one of the problems is you end up with an overdose. You get hyponatremia, at least at the neural cell level, and patient will develop hypotension, cardiac dysrhythms, and cardiovascular collapse, and it's treated with usually hypertonic saline, 1.5% saline, and forced diuresis to forcibly remove the lithium and replace sodium. So mostly, though, overdoses of lithium are mostly intentional or gestured, and they're presented with cardiac abnormalities and hypotension. So you treat the cardiac abnormality, the hypotension as needed, and we'll worry about the forced diuresis. Okay, so now I gotta find my case reviews. All right. We've got some, like I say, some really interesting case reviews. Okay. You want to talk about this one?
Do I want to present it or just?
Well, you can talk about it here. I'll present. We'll start it. Okay. Code 3 response on a rural road. That's hard to say, you know, rural road for a report of a rollover. God, dirt. Yep. ATV accident with one patient ejected into a ditch. Weather conditions nice and clean and dry at 28 degrees. Info difficult to obtain because everybody is speaking something other than English. It's Russian or some such. Eastern European. Family member that spoke some English states the patient and another family member were on a four-wheel ATV when the ATV hit a large electric junction box, causing the patient to be ejected an unknown distance, landing into a ditch. I suspect she hit the junction box on the way too. There was no info on the speed, who was driving. The patient was not wearing a helmet. Otherwise, the patient was wearing a winter coat, jeans, and boots. Prior to the EMS arrival on the scene, life flight was placed on standby to expedite transport if need be. Ground transport time to PH Southwest would have been approximately 30 to 40 minutes due to road conditions and distance. This is in the ice and snow stuff. Patient was found in a rural airway on a long backboard, yelling in Russian and attempting to pull her sea collar off. Had a patent airway bleeding noted from the nose and mouth, moving all four extremities, had notable bleeding from the back of the head. Quickly moved the back of the ambulance to prevent any weather-related complications. The heater in the, well, actually hypothermia is not a bad. Once in the back of the ambulance, clothing cut off, rapid trauma assessment. Head, deformity, edema, swelling, and fracture, moderate bleeding from occipital portion of the head with deformity. Face is deformed, edema, traumatic fracture, closed and raccoonized Levophed 3 fracture with displaced upper and lower palate. Patient had minimal blood from mouth and nose. Displaced trachea to the left lateral aspect posterior to the cricoid. Chest, large amount of adipose tissue. Abdomen, obese, soft, atraumatic. Pelvis stable, back unable to assess. Right wrist fracture, closed, no other deformity. Due to patient's altered mental status, severe facial trauma, and transport on a helicopter, the patient was prepped for RSI. Patient placed on high-flow nasal cannula for pre-oxygenation. As medications were being administered, patient had a precipitous drop in O2 sat. Attempted to reoxygenate the patient. No success, large amount of resistance of the BVM, severe facial trauma. Determined the patient needed immediate intubation. Severe bleeding coming from the airway, facial trauma, failed intubation attempt, patient prepped for surgical airway. You want to take over?
Sure. You want to come up there?
Sure. Come up here, that way you can speak into this and it's recorded for posterity.
All right. Can you hear me? All right. So, yeah, the patient initially was doing fine, at least vital signs wise was doing fine. She had a pressure, if I remember correctly, like 140, something like that. Her heart rate was about 101. SATs were initially 93, 94%. Again, like I said, we knew we were going to have to RSI an intubator. As I didn't even hook up just hooked up the syringe to start pushing the RSI drugs, and she just went out. Her SATs dropped almost immediately down into the 80s and continued to decline at that point. we couldn't reoxygenate her. I told my trainee at the time that we needed to get the tube now. Just had to be done. He went in to intubate, and as I saw him go in to displace the tongue, and her upper palate was just hanging down. It almost looked like she had dentures, and when someone has dentures that are loose, and I realized that they weren't dentures, it was just her upper palate that was hanging. He attempted to visualize the glottic opening, couldn't do it. All it was black, lots of blood, tried suctioning, just wasn't going to work. It was determined that we needed to move to the surgical airway. While he and the firefighter were attempting to reoxygenate, I prepped her neck for surgical airway. So assembled the equipment and started to make my vertical incision. As I started cutting down and moved through the adipose tissue, started to experience quite a bit of bleeding. It was more blood than I anticipated, having not had done a surgical airway on a live patient before. Continued to cut down. We suctioned continuously and moved down to where we were past the adipose tissue. Again, she was probably 5'5", if that, maybe 110 kilos easy. So I had a large neck, I mean, I couldn't palpate any identifying landmarks before the incision. So I just did my best to look midline and start cutting. The bleeding started, got down, palpated the thyroid cartilage. I knew that all I had to do was essentially move down, and then I would have the cricothyroid membrane. I moved my finger down and there was no membrane there. That's, in all honesty, at the point where I didn't want to be there anymore. It's, after teaching the stuff for many years and doing it on mannequins and whatever, it wasn't what I expected. So I was having an internal, I want to go home, I don't want to do this anymore. Thought I was killing this patient right in front of me, and I was not happy. At that point, I, by the grace of God, moved my finger to the left and realized that her trachea was displaced to the left. Of course, I couldn't see that it was obviously displaced because there was so much adipose tissue. At that point, I made my incision into the trachea, or what I thought was the cricothyroid membrane at that point. I tried to insert the Shiley. The problem was that when I made my initial incision into the trachea, it was not large enough to fit the Shiley. So I pulled the Shiley out. The stylet that goes with the Shiley went into Never Never Land and was gone. And I made my incision bigger, stuck my finger in her trachea. I mean, I buried it as far up as I could because I wasn't about to lose that side at all. Gerard, my trainee, cut down a 6.0 ET tube. We inserted it in end tidal, and we had bilateral lung sounds at that point. We secured it, and the bleeding at that point had pretty much stopped. So O2 sats were coming up. At that point, reassessed the vitals. Her blood pressure actually went up, and her heart rate really never dropped below, I believe, 90. So thankful for ketamine for that purposes. At least that's what I'm attributing it to. Moved towards the landing zone. On the way to the landing zone, it wasn't a very long transport. This was up at like 240th and Berry Road. For just reference, if you know where that's at, I had never been up there, and it was way out there. So moved to the landing zone. On the way to the landing zone, reassessment of vital signs and lung sounds. Noticed that her left side was decreased, and again, in all honesty, had my adrenaline not been running at probably 20-fold, I would have thought, oh, maybe the tube slipped down, I should have pulled the tube back. Nonetheless, I decompressed her, and we didn't really have much of a change. Life flight crew came in and gave them report, suggested to them that they needed to assess the left side of the chest for a possible at least hemopneumoretention pneumothorax. We moved her to the helicopter. As we were loading her into the helicopter, she started breathing again on her own, so the sucks and ketamine had started to wear off. They decompressed her en route, again with no change, and then she went straight to OR to a manual. So I assume you have the list of the
Yeah.
problem list.
So, and the, one note here, the ETCO2 was difficult to obtain because the
Yes.
LP15 kept purging.
Yeah, I'm sorry, that's a good point. So we initially had N-Tidal, and we tried different lines, and all it kept saying was purging, and I'm guessing that's due to the amount of fluid that we were dealing with
Yep.
at that point, so.
Yep. Okay, so this just tells all the stuff that we just went through. Pulse oximeter, here's what she ends up with. TBI with a small subarachnoid, bilateral Lefort 3s, nasal fracture, mandible fracture, right first rib fracture, sternal fracture, left scapular fracture, right radius fracture, bilateral pulmonary contusion, bilateral pneumothorax, dysphagia secondary to the facial injuries, ultimately acute protein and calorie malnutrition, which is kind of surprising with a,
Yeah, right?
yeah. Acute blood loss anemia and acute respiratory failure. So those are all the problem lists, but she did find the feedback from the trauma surgeons and the facial surgeon was that the trach was, that the surgical trach was just fine, despite the anxiety at the time.
Yeah, I think it was after the call was over, and again, internally, I think Gerard, I think everybody in the back of the ambulance was, at least internally, thinking this is taking forever, we're, just, it feels like forever, but if the treatment and responses are up there, the actual time from the start of drug administration to securing the actual surgical airway was, I think, 4 or 5 minutes, and that was with an intubation attempt in there. I think it seemed like 4 hours, but it certainly wasn't as bad as I thought it was.
Sphincter spasm is related to that thing. It seems like it goes on forever.
Yeah, absolutely.
So, now. All right, case 2. Hey, maybe we have somebody here from Camas on this one too. This is a 19-year-old in driver's seat. Patient is the restrained driver traveling freeway speed, striking the rear of a stationary fire engine. They're just so hard to see at night with the lights on. There's an intrusion. Well, let me show you the vehicle. You can see this is there's the engine there. It's in the front passenger compartment or front driver compartment. Any rate, significant damage, a collision witnessed by E41 and M41 crews because they're at another motor vehicle accident. All the cones are out, everything, and interesting enough, the patient is lucid immediately after this event, speaking full sentences. GCS is 14, perseverating a bit, improves to 15. Skin cool, pale, and dry. Chest, no crepitus or deformity. Superficial abrasions of the face. Abdomen, superficial abrasions. Extremities, unable to assess initially. Lower extremities, because engine compartment is pushed up onto his pelvis. Upper extremity, point 10 to the left elbow. Lower extremity, right rotated, mid-thigh deformity, open fracture, full thickness avulsion, degloving of left knee, left mid-thigh swelling, etc. So, vital signs: blood pressure is initially unobtainable, heart rate 126, respiratory rate 28, life flight was placed on standby. Life flight activated after rescue team estimates patient extrication up to 40 minutes. Tell me about the extrication. How'd you get that all pulled apart?
We took off the rear driver's side of the door and then had access to the patient while we removed the roof, and then pushed the driver's front door, massive metal and dash, and we slowly pushed that away, and then we were able to manually lift all that stuff up once it got loose.
So you lifted him up out of the vehicle through the top?
Then he kind of
Top was off?
out the back,
Okay.
kind of out the back driver door.
So we got IV fluids, extrication with heavy rescue tubes. How long did it take, do you think?
I think the initial call to dispatch that we did get to transport was 35 minutes.
So your extrication was maybe 25 minutes? Oh. Palpable radial pulse, patient legs and pelvis freed from vehicle. Patient complained of significant bilateral leg pain, 100 mics of fentanyl IV, extricated along backboard. There's another picture of the vehicle and the back of the rig. Life flight ETA approximately 5 minutes after patient was fully extricated, and so they determined that ground transport was more feasible. Patient loaded to MICU, transported code 3, vital signs, blood pressure 118/80, heart rate 120. No secondary assessment, no significant changes, warmed en route, no change in findings, transported to staff. Here's what we had. 19-year-old, prolonged extrication, intubated, had CVC placed in ED, resuscitated with blood products in ED, and evidence of bilateral femoral fractures, distal humeral fracture, several large lacerations in the knee and wrist. He also had bilateral anterior thigh Morel-Lavalley lesions. Okay. Morel-Lavalley lesions are closed degloving injuries caused by shearing of tissue, just pushing it. So he had, and you end up with getting tremendous fluid accumulation in these, and they ultimately have to be drained and all that, more at risk for infection, all sorts of stuff. But it's a closed degloving injury. Morel was a French surgeon, described this in 1856 or so. I don't know what sort of war was going on in France at the time, but they figured it out. So, CT showed non-displaced rib fractures, multiple, a non-operative grade 3 liver laceration and a grade 1 splenic laceration, questionable abnormality of the C-sweep of the duodenum, no evidence of free air. Went to the OR immediately for ortho wound repair, Steinman traction pins in both femurs to allow traction until you could do a operative internal fixation later on. He'll need an ORIF, internal fixation of distal humerus as well. It was an interesting thing about this is he had a negative alcohol and a negative drug screen. So why does a 19-year-old run at high speed into the back of a stationary ambulance? He's just not paying attention, I guess, or whatever. He's 19. Did we find a text? Did we find a phone there? Well, so, gosh, I never noticed that ambulance or that vehicle. Okay. This is not a trauma. So, I mean, it's another really good, very rapid extricating, good choices on, on how to get the patient there, and the patient did amazingly well despite. What's amazing is no head injury in all this. So, 39-year-old female, husband on scene says the patient has a past history of Addison's disease. Also, partial hysterectomy, esophagitis, obesity, depression, and anxiety. High doses of steroids, by the way, can cause depression and sort of other mental status changes. Patient's not feeling well with transient slurring of speech throughout the day, leading to current acute loss of consciousness with apnea. Patient lowered to the floor by the husband. He called 911 and began CPR. Then she awoke and then again went into what appeared to the husband to be a cardiac arrest, and he started CPR again. When EMS gets there, the patient is apneic with a pulse. Unconscious, unresponsive to all stimuli, transient episodes of lucid intervals in the midst of all this, and then goes back to unconscious, unresponsive, and apneic. Skin's warm, pale, and dry. Chest equal expansion. During lucid intervals, patient speaks in nearly full sentences with labored respirations and tachypnea. No resistance, however, to BVM assistance when she's unconscious and apneic. Moves all four during lucid intervals. ETCO2, nasal cannula with ETCO2 applied. Sinus tach without ectopy. Blood pressure is 180/120. Heart rate 130. IV attempts. Obese, difficult landmark, 4 attempts. Discuss solumetrol dose with medical control, complications of paralytic use, cetonidate versus ketamine, any complications with ACLS meds in setting of Addison's. The answer is no. Complications just, and the solumetrol dose is just your normal solumetrol dose or double, doesn't make any difference. IO insertion via bariatric needle to left tibial plateau. Tuck that away. Flushed with 10 mils of saline. Who was on that scene? Anybody here?
No, but I can speak for it.
Okay, but was the bariatric needle picked because she had a really fat leg, or because?
They put a blue 25 millimeter needle on and went to the hub. 5 millimeter line was not visible, so they went to the larger.
Okay. Well, that's the answer. It didn't say that in the chart, so I couldn't follow that. It's always nice to put that in. So, 125 milligrams solumetrol given. Patient continued with apneic unconscious periods, 2 to 10 minutes, lucid periods, 12 lead, log roll, transport. She got 200 milligrams of ketamine, 150 of sucks. Apnea after sucks with visualization of chords. Patient with acute onset of alert and oriented with spontaneous respiration during visualization attempt. Put that away. Tuck that away too. Well, we'll find there's a reason. Taken to MICU, patient unconscious but with respiratory efforts assisted via BVM, transported code 3 to Peace Health. Patient now apneic. Reattempt visualization via King Vision with difficulty due to small mouth. Successful visualization with a MAC blade intubated with 7/0 tube. Confirmed, etc., etc. Blood pressure 186, heart rate 132. IV fluid administered via IO with pressure infuser. Increased mentation and respiratory attempts on the way to the hospital. Got some Versed. Heart rate of 144, ETCO2 of 54, more Versed, heart rate's okay, ETCO2 is 50, ET suctioned with blood-tinned sputum, handed off to ER staff. Well, here's some strips and all. in hospital. It reported cardiac arrest at home with preceding general malaise, had improved mentation, ROSC with CPR by husband, has sinus tach on EMS arrival, difficult IV access, so IO was attempted in the left proximal tibia with the bariatric needle. In ED, patient is found to have signs of compartment syndrome in the left lower extremity. So ortho took her to the OR for a 4-compartment fasciotomy, which was notable for evidence of propofol, which had been given in the ED in the soft tissues of the posterior superficial compartment, which means that the fluid, the Valium, the succinylcholine, the initial ketamine, etc., was probably going into the soft tissue fascial compartment rather than into the marrow. So this was all building up in there, which kind of explains why after 200 milligrams of ketamine and 100 of sucks, she woke up and starts moving around. So it took a while to take effect, and the propofol didn't do much good at all, I guess, probably when it's sitting in there. Anyway, she did okay with the compartment syndrome. Now, cause of the altered mental status versus the arrest, at the time we wrote this, they didn't know what was going on. She has no evidence of ischemia, no conduction abnormality, et cetera, et cetera. No. So IO malplacement is a known potential complication. I guess the blue needle didn't work. It didn't go deep enough. Now, unless we were into the bone and didn't realize it, because there was not enough resistance.
So it was buried in the hub, is that what it was?
Yeah, so the
Probably just
blue
went
needle,
through
they
the
actually-
tibia and into the posterior.
without depressing the
compartment.
trigger,
Yeah.
it went all the way to the hub.
Yeah.
And still didn't heal the bone.
So they didn't.
The large needle went in, and then they did heal the bone, but at a deeper depth, 25 millimeters.
Is-
Pop as normal.
It what?
What's that?
It did pop? You said?
Pop, only pop one time. Tried to aspirate that out and flush.
Well, that's hard to explain, because it's really hard to imagine that it would have got into the posterior compartment without going all the way through the tibia.
Have we had another one of these, or is
No.
this the first one?
First one we've ever had
It's
is
pretty
a,
rare,
yeah, it's rare enough.
but it is a known complication.
It might have
Especially
been,
it's a high-risk patient with the anatomy. You
Yeah.
have it as being so.
and if she's really got Addison's disease and has been on chronic steroids and stuff, she may have a little bone density issues.
One thing you could consider is just cutting down to the bone.
Yeah.
You know, and then inserting it that way.
Yeah.
So it's
They don't-
in somebody with a lot of adipose.
They don't carry knives for that reason.
Oh, they don't?
Not like us. Now, one other thing to mention, just as an aside thing, I noticed that it was difficult to use the King Vision didn't seem to work, and so a regular Mac blade was used. I've been doing some talking with some of the folk in Portland, as well as just doing some more reading, and the screen guided, the things like the King Vision or the Glide Scope and everything are not quite the panacea that they've been arguing that they should be. That they're still. It's still really operator dependent, and it's what you're used to, and there's as many failures with a glide scope as there are with a regular laryngoscope, probably. But it's whatever, you need to have both things to be able to, cover all bases. Okay, last case. Interesting. Informed by CCSO, a patient had been shot multiple times with a small caliber handgun by a male suspect in custody. Informed that they had located a single gunshot wound that entered the lower abdomen, exited through the posterior gluteus. Due to patient's AMS, no further info obtained. Patient found supine on ground. At patient's side, Israeli bandage and IV established. Patient was moaning but very lethargic and slow to respond. Due to bandage around abdomen, no visualization of gunshot wound made by EMS. Does the Israeli bandage work on an abdominal wound? Not really. Yeah, that's what they had. There was very little bleeding noted. It was controlled PTA. She was moved to a trap and placed on backward on a gurney. She transferred code 3 to medical center. Due to decrease in mentation, patient was RSI'd en route to ED. No further change in condition, care transport. Upon arrival at ED after patient exposed by ER staff, trauma surgeon noted a second gunshot wound entering pubis with exit to the posterior vagina. Yep. Informed by CCSO that patient had been shot multiple times. Informed us, okay. All right, well, this is, I guess I'm going backwards here. GCS 14, blood pressure 120, pulse 72, which is kind of interesting. Why would you think she might have she's got a blood pressure of 120. Okay, that's probably normal. Pulse is 72. Why would she have a slow pulse? I would think she'd have a more rapid pulse than that. Suppose she could be on medication. She could also be, this could be indicative of blood in the abdomen. Little vagal. Pulse ox 99, trauma alert full. Okay, succinylcholine, etomidate, and intubated easily, apparently. CO2 44, got some midazolam, CO2 42. So, what she ends up with. X-rays confirm position of ET tube, no evidence of pneumothorax, no free air or retained metallic foreign body in abdomen or pelvis. OGT, orogastric tube and a Foley were inserted, no evidence of blood in stomach or bladder. She went directly to the OR, penetrating wound to the abdomen, of course, where injuries were noted to the ascending colon, several injuries to the small bowel. Right hemicolectomy was done and enterotomy is repaired. She recovered in ICU, developed bilateral pleural effusions requiring bilateral chest tube placement and intra-abdominal fluid collection that was addressed with CT-guided drainage. She did develop thrombocytosis, low platelets, high platelets. Was noted to have portal vein thrombosis, which is treated with IV heparin in the hospital, and she gets about 6 months of anticoagulation, discharged on 2/16. So it was a nice job by EMS crew, no delay at the scene. She got very quickly, and she is kind of the poster child for getting shot a couple times in the abdomen. You get all sorts of things that happen intra-abdominally even after early surgery repair. The thrombocytosis is a overreaction to the, she probably has a family, if you look at a genetic family predisposition to deep vein thrombosis anyway. Portal vein thrombosis is not good, so because portal vein takes everything to your liver, you kind of like to keep it going that way, but she got relatively easily fixed with IV heparin. Okay. So a series of some very nice EMS cases. All right.